I'm here in Chicago 2025. I just presented the FAHF2 trial, and really I'm very happy to answer a few questions. And thank you for the first question. The pathophysiology of iron deficiency. Well, basically when you're chronically ill, you develop iron deficiency because of inflammation. Inflammation causes that the iron is trapped inside cells, inside gut cells, inside macrophages, and is not enough available for the use in the rest of the body. Why is iron important? Well, for two reasons. Number one, we need free iron in the body for metabolism to produce red blood cells, to then support the carrying of oxygen to the peripheral tissues. But second, we also need iron to make the energy production more efficient. In each cell, you have the respiratory chain reaction, and iron is a catalyst for it. So when you have iron deficiency, you get less oxygen transport and less oxygen utilization. And correcting iron deficiency will enhance the patient's well-being and reduce events. The current recommendations and guidelines basically say that when a patient with heart failure and a reduced ejection fraction is symptomatic and has iron deficiency, then the patient should be treated with intravenous iron, and the intravenous iron should basically correct the iron deficiency. You should basically give at least 1,000 milligrams of intravenous iron, and if the patient has a body weight above 70 kilograms, add another 500 milligrams. If the patient has a low hemoglobin below 10, add another 500 milligrams. So giving intravenous iron 1,000 to 2,000 milligrams is basically the base treatment. And then in the continuation, you basically look whether any of the indices of ferritin or TSAT go far too high, then you stop the treatment. Otherwise, every 4 months, you give 500 milligrams. It is important to understand that iron deficiency happens in patients with and without anemia. Anemia and iron deficiency are two problems, not only one problem. So we want to correct iron deficiency both in patients with and without anemia. And when we do correct iron deficiency, we have found you can improve symptoms, you improve quality of life, you improve the exercise capacity, like the 6-minute walk test, but you also reduce heart failure hospitalization events. In the FAHF2 trial, we had 3 primary endpoints. The first primary endpoint was the time to the first event of heart failure hospitalization or cardiovascular death, and we reduced it by 21%. The recurrent heart failure hospitalization, so first, second, and third, they were reduced by 20%. And in the subgroup of patients with a low TSAT, we also had similar benefits as in the treatment group overall. That means basically we can use the standard definition of iron deficiency with a low ferritin value below 100, or if ferritin is below 300, then with a TSAT less than 20, or we simply say a TSAT less than 20 alone is a definition for iron deficiency. Our trial confirms all of this.